Hello, I'm Dr. Spoorthi, General Physician and Endocrinologist at Akkineni Hospitals. I hope you're in good health. Let's explore some key aspects of today's topic. Please stay with us and note them.
Okay, let's dive straight into this explainer. We're going to demystify a frustratingly vague term that millions of women hear literally every single year: irregular periods. It's actually one of the most common complaints in gynecological practice. But here's the catch: it means something completely different depending on who you ask. For one person, it means their cycle is late. For another, it's a super heavy flow. And figuring out the actual underlying cause is a total game changer. It determines everything from how you manage your day-to-day life to huge implications for your fertility. So today, we're giving you the exact medical vocabulary to understand what's happening in your body. We are ditching the jargon and giving you the tools to take charge of your health. Let's get into it. Here's our quick roadmap for today. First, we'll define a normal cycle. Second, we'll look at when cycle timing shifts. Third, we'll tackle heavy flow and pain. Fourth, we'll cover atypical bleeding red flags. And finally, we'll break down the exact medical investigation framework. All right, Section 1, defining a normal cycle, or establishing our baseline. So, to understand what makes a cycle irregular, we first have to build a really concrete, scientifically accurate picture of what's normal, right? I mean, you can't spot an abnormality if you don't know the baseline. It's a question doctors hear all the time. What exactly makes a period normal? So many of us are just taught to log days on a calendar app, but we almost never learn the actual clinical numbers that define healthy menstrual function. Let's fix that right now. Here is the absolutely crucial point. A normal menstrual cycle length falls somewhere between 24 and 38 days. Now, remember, you measure this from the very first day of one period to the first day of your next one. But what's really vital to know, and honestly a huge relief for a lot of people, is that a cycle-to-cycle variation of up to 9 days is still totally within the normal range. So if your cycle is 28 days one month and then 35 days the next, medically speaking, you're absolutely fine. You're still operating perfectly within normal parameters. Okay, let's talk about the exact numbers for flow and volume. We already know the 24 to 38 days cycle length. But for menstrual flow duration, normal is actually 4 to 8 days. And then there's the blood loss, 5 to 80 milliliters per cycle. Honestly, anything over that 80 milliliter mark is considered objectively heavy. Now, obviously, doctors know you aren't measuring milliliters at home. So the real-world clinical signs that you're exceeding this limit include passing large clots, flooding, or having to soak through more than one pad per hour for several consecutive hours. Moving right along to Section 2, when cycle timing shifts, or as I like to call it, understanding the areas. Let's see what happens when those baseline parameters start falling out of range, starting with the timing of your cycle. Now, you're going to hear the suffix "roria" a lot today. It basically just means flow or discharge. First up is oligomenorrhea. If your cycles are super infrequent, this is the exact term your doctor is using. We're talking about a cycle length greater than 38 days, meaning you get fewer than 9 periods a year. When this happens, conditions like PCOS, polycystic ovary syndrome, are often the primary suspect because of how it disrupts hormone levels. But doctors will also look at thyroid issues or even severe stress, low body weight, and over-exercising, which can literally shut your reproductive hormones down. Now, on the flip side of that, we have polymenorrhea. These are highly frequent periods where your cycle is shorter than 24 days. If your period is constantly arriving this early, it can actually point to anovulatory cycles, meaning your body isn't actually releasing an egg that month. It's also a super common sign that someone is entering perimenopause, or it could even point to an underlying issue within the uterus itself. And then we have amenorrhea. This is the complete and total absence of periods. But from a medical standpoint, we can't just stop there. To properly treat it, doctors have to split this into two very distinct categories. It's amazing how the timing of when the periods stop completely changes the medical investigation. Primary amenorrhea is when someone hasn't started menstruating by age 15, or by 13 if they have no other signs of puberty. This sends doctors looking into developmental genetics for structural or chromosomal abnormalities. Secondary amenorrhea, however, is when someone who already had established periods suddenly stops having them for 3 or more months. And guess what? The very first thing a doctor absolutely must rule out here is pregnancy. If that's clear, then they'll investigate things like premature ovarian insufficiency, coming off the pill, or the stress factors we talked about earlier. Let's head into Section 3, heavy flow and pain, medically known as menorrhagia and dysmenorrhea. We're transitioning from the timing of your cycle to the actual physical experience of it. Let's talk about menorrhagia first. Remember that 80 milliliter baseline we just talked about? When your blood loss exceeds that limit so much that it's actually ruining your quality of life, it's officially menorrhagia. And doctors don't just guess here. They look for concrete structural issues. We're talking uterine fibroids, adenomyosis, or polyps. But surprisingly, it can also stem from systemic issues like a thyroid condition or a bleeding disorder. In fact, a bleeding disorder like von Willebrand's disease very frequently shows up as menorrhagia in teenagers. Okay, let's talk about pain or dysmenorrhea. Pain is a massive deviation from a healthy baseline, but just like a missing period, we have to categorize this pain to track down the root cause. The really crucial point here is distinguishing between two very different types of pain. Primary dysmenorrhea is basically standard cramping caused by chemicals called prostaglandins. There's no underlying structural disease here. It usually starts when you're a teenager and thankfully naturally improves by your late 20s. Secondary dysmenorrhea, on the other hand, is driven by a structural issue. Think endometriosis, adenomyosis, or fibroids. A huge flashing warning sign for doctors is if the pain progressively gets worse over the years, if it suddenly starts after years of painless periods, or if it's accompanied by deep pain during sex. All right, Section 4, atypical bleeding red flags, and when you absolutely need to seek prompt care. We really need to shift our focus to atypical bleeding now. These are absolute clinical red flags that require immediate medical attention, no waiting around. First is intermenstrual bleeding, or spotting between your periods. Now, sometimes this is completely harmless, like a little spotting when you ovulate or your body adjusting to birth control. But it can also point to really serious cervical or endometrial issues. And a critical absolute red flag here is postcoital bleeding, or bleeding after sex. That is a strict clinical trigger, and it must be investigated immediately by a doctor to rule out cervical pathology. Next up is postmenopausal bleeding, or PMB. The rule for this is incredibly simple but strict. If it has been a full 12 months or more since a woman's last period, any vaginal bleeding at all, even a tiny bit, is a major medical event. Now, you might be wondering why the medical community treats this so seriously. Well, even though most of the time the causes are actually benign, things like polyps or tissue thinning, the sheer numbers explain why doctors take zero chances. 90% of endometrial cancer cases present as postmenopausal bleeding. Because of that single fact, immediate medical investigation is non-negotiable. Finally, Section 5, the Medical Investigation Framework. This is your diagnostic action plan. Look, having the right information is basically having a superpower. So let's walk right into the doctor's office together and replace that fear of the unknown with a really comforting step-by-step action plan. This is how your doctor stops guessing and starts targeting the exact problem. Step 1, always a pregnancy test for anyone of reproductive age. Step 2, a pelvic ultrasound. This lets the doctor actually see your uterine structure and your ovaries. Step 3, a full blood count. This is super vital to check for anemia, especially if you've been dealing with heavy blood loss. And Step 4, the hormonal profile. For that hormonal profile, your doctor isn't just looking at one single thing. They are running a comprehensive panel to put together your unique hormonal puzzle. They're going to check your FSH, LH, and estradiol based on where you are in your cycle. They'll look at your TSH to check your thyroid, plus prolactin, and AMH to see your ovarian reserve. And if they suspect PCOS, they'll specifically check your androgen levels too. It's a full body snapshot. Wow, okay, we've covered a ton of ground in this explainer today. Irregular is no longer just a scary mystery word, it's the exact starting point for a very specific medical conversation. So take this knowledge, use the framework we just outlined, and demand specific answers from your provider. Keep decoding the incredible complexity of your own body. So my final question to you is this. Now that you know exactly what to look for, how will you advocate for your own reproductive health at your next appointment?